Hello, everyone. Hi. My name is Kim Rubenstein. Hi, John. My name is Kim Rubenstein. I'm the program coordinator and parent liaison for Be a Part of the Conversation. On behalf of the many volunteers who make events like this possible, welcome and thank you for spending an evening with us. I'd like to thank the 20 or so facilitators who have volunteered their time tonight. After Dr. McLellan's presentation, we will be forming small groups and we'll each have a facilitator with us who will simply take some notes and help to guide the conversations. And can I ask our facilitators to please stand and be recognized? I want to thank you guys very much. I'd also like to thank the folks that are stationed at the tables that are set up around this room. If you haven't done so yet, hopefully before you leave tonight, you'll have a chance to take a walk around and visit some of those folks. They're here from a lot of different treatment centers and other support resources, so please take advantage of the information that they have at the tables. And at the very back of the room is the Be a Part of the Conversation table. We have a lot of great support back there as well. Lots of information to pick up. And we also have an opportunity to sign up for our mailing list so that you can get our emails and lots of good stuff. Oh, and also want to make sure I get in a plug for Parent Partnership. This is a parent support group that meets every Thursday at 7 p.m. all year long. We meet right down the street here on Horsham Road, and we just talk about parenting and some of the struggles that we have. It can be just about anything. A lot of times we do, to be honest with you, we talk a lot about drugs and alcohol and the way it impacts our children. But really anything that parents are struggling with, it's just a nice, safe, confidential place to come and talk and share our experiences. I'm excited to share some news that is very relevant to tonight's conversation. One of the risks of prescription drug abuse is having unused or expired medications in our homes where they could be tempting to others who either live with us or are visiting our homes. On April 26th, the Horsham Police will host our 5th drug take-back event, which we have flyers for in the back that look like this. It's right up the street at Giant. But even more exciting than that, Horsham Police Lieutenant John Clark. John is in the very back. Give us a big wave, John. There he is. John Clark has been working with State Representative Todd Stevens to install a permanent lockbox just inside the entrance of the Horsham Police Station, right across the driveway. That will be accessible 24 hours a day, 7 days a week. That will be in place in about the mid to late April. But they're working hard to have that in place. So when we do our drug take back, we're going to be letting folks know that from that point on, we will have a permanent place to take them so that the drugs do not need to stay in your home once you're finished with them. And that doesn't have to be prescription drugs. It can be over-the-counter meds or vitamins or anything you just want to get rid of. So let's see. Oh, and on behalf of Be a Part of the Conversation, our hope for this evening is that we will take away some very important knowledge about prescription drug abuse. Tonight, we are parents, friends, educators, treatment professionals, healthcare providers, and healthcare consumers. It is vital that we do all that we can to understand the changing world we live in with regard to medications and the potential for the abuse that they may present. Our very special guest tonight is Dr. Thomas McLellan. He is the CEO and co-founder of the Treatment Research Institute and an experienced substance abuse researcher. In 2009, he was named the Science Advisor and Deputy Director of the White House Office of National Drug Control Policy, a congressionally confirmed presidential appointment to help shape the nation's public policy approach to illicit drug use. During that time, Dr. McLellan worked on a broad range of drug issues, including formulation and implementation of the President's National Drug Control Strategy and promotion of drug treatment through the broader revamping of the national healthcare system. Dr. McLellan has more than 35 years of experience in addiction treatment research. In 1992, he co-founded and led the Treatment Research Institute to transform the way research is employed in the treatment and policy making around substance use and abuse. In his career, he has published more than 400 articles and chapters on addiction research. He has served as editor-in-chief of the Journal of Substance Abuse Treatment and has also served on several other editorial boards of scientific journals. Dr. McLellan is the recipient of several distinguished awards, including the Life Achievement Awards of the American and British Societies of Addiction Medicine, the Robert Wood Johnson Foundation Innovator Award, and awards for distinguished contribution to addiction medicine from the Swedish and Italian medical associations. In the 1980s, with his colleagues from the Center for the Studies of Addiction at the University of Pennsylvania, Dr. McLellan introduced the Addiction Severity Index, and later the Treatment Services Review. Both are among the most widely used assessment instruments in the world. Please help me to give a warm welcome to Dr. Tom McLellan.
Thanks, Kim. And I guess first thing I want to say is thanks for welcoming me, and congratulations. It's very important to be part of the conversation here. Because the thing I think I want to leave you with, I'll talk a little bit, but if you fall asleep in the middle, here's what the take-home is. There are things that can be done, and people aren't doing them. So it's not like this is an intractable problem. There are solutions. There are things that can help. So let's talk a little bit about prescription overdose. And I was just saying to Kim, if you're saying, I don't want to hear about that. We have a heroin problem up here. Well, prescription drug abuse is like prep school for heroin abuse. It prepares you for heroin abuse. And it's not just physician responsibility. Patients have responsibilities. Government has responsibility, and pharmacies do. So I want to talk a little bit about this, and I'll go pretty quickly. I think we'll have time for questions, and let's just see. So very important to understand something. There's a very big difference between use of a drug, any drug, alcohol, cigarettes, opiates, cocaine, marijuana. Use is controlled by access, availability, price, all the things that make other commodities attractive also make drugs attractive. If you want to sell more iPhones, cut the price, make more outlets, make them more available. You want to sell more drugs? Make them legal, make them more available. Okay? That's use. Now, abuse is when you use even though that use is potentially going to harm you or your environment. Drinking and driving, drinking and being pregnant. That's abuse. What controls that is consequences closely following the use. If every time you smoked marijuana when you were a kid, your mother caught you and took away your driving privileges for a week, you mostly would stop because the use was under your control, but consequences are the thing that bring it under control. So places where abuse occurs a lot are places where there aren't consequences. Here's one, fraternities. Excellent breeding ground for later addiction, alcohol or other drug addiction. Now, the reason I go through this is because people regularly think drug addiction is simply a lot of use or a lot of partying. That's wrong. It certainly involves a lot of use, but along the way, something happens in your brain. We don't know how it happens, but we do know what happens. Your brain changes, and it changes in very predictable ways. It changes more if you use earlier, like in your adolescence. And not just everything changes. It's the good stuff. It's inhibition, ability to concentrate, ability to motivate yourself, but particularly your ability to control your behavior is all altered. And it's almost certainly due to genetic expression. Not everybody gets addiction, and it has prompted lots of people to think, yeah, well, the people who get addicted, well, they're weak-willed. They've got bad morals. They've got bad parenting, something like that. Maybe, but the thing that flips that switch is almost certainly a genetic factor. Well, that's interesting, Tom. So what? Well, here's so what. Let's look at the way substance use, abuse, and addiction look in the country. So here's a little picture of how drug use looks in the United States. And on here is, this is just adults, and it's all drugs other than cigarettes, okay? So it's a pyramid, and at the bottom of the pyramid is where the majority of the population is. They don't use drugs or alcohol, and if they do, they use very rarely. Most people think the United States has the worst drug problem in the world. Not even close. Russia has the terrible drug problem, way worse than us. Poland, many other countries. What we do have down here are people who do not drink or use drugs of any type and never do. We have higher rates of abstinence than many Muslim countries where alcohol is strictly forbidden. Okay, now if you start going up this pyramid, you're going up in terms of from no use to a lot of use, more severe, more complex. Well, when you get to about here, sorry for you guys over at the corner, I don't mean to leave you out, but that's where substance use disorders start, not addiction. That's where abuse begins. Now, it's a wavy line because it changes, and it's got holes in it because people go back and forth across that line. But the big deal is there's a lot of them. There's about 60 million people who use in a harmful manner. Let's say a young woman is drinking 2 drinks of wine every night. Is there anybody here who thinks she's addicted? No, she's not addicted. Not at all. That's approximately normal, a little bit high normal range, except for one thing. I forgot to tell you. She's pregnant. Oh, different story. That is harmful use, medically harmful use, not just to her, to her fetus. Fetal alcohol syndrome is now known to be the #1 cause of brain damage in the world, drinking while pregnancy. Okay, I could give you more examples, but let's keep going up the pyramid. Okay, now you get to this line right here. Nice, crisp, bright, clear line. Now you're in Charlie Sheen territory, okay? This is addiction, okay? And there's about the same number of people who are addicted, which is the most severe, complex, chronic form of substance use disorders. There are about the same number of those as there are people with diabetes. Everybody knows there's a huge epidemic of diabetes in this country. Well, there are as many people with very serious substance use. And at the very top, if you're in the back, you probably can't even see that little pinnacle, that orange pinnacle at the top. That's the number of people who are getting any kind of treatment. So you can see it's less than 10% of people who are seriously addicted, but it's less than 1% of the people in the whole pyramid. So we're nowhere close to addressing the substance use disorders in this country. We could, we haven't committed our resources in the right way. Okay. Let's talk a little bit about prescription opioid abuse. Basically, pain management medications. And I'll talk about how it started. I'll tell you the end before I tell you the middle. Prescription opioid overdose is now the #1 or #2, depending on which state you live in, but it's usually the #1 cause of accidental death in this country. Now just stop and think about that. If I said, what do you think kills more people accidentally than anything else in this country? Almost every person in this room would say, oh, God, it's got to be car accidents. No. #2, prescription opioid overdose. Not heroin. Prescription opioid overdose. It's unthinkable. And here's how it started. In 1997, the major pain societies in this country probably correctly concluded that pain, chronic non-cancer pain, was being under-medicated. People were needlessly suffering. And sometimes there weren't, there was bad training for physicians, but often there was this worry that patients would get addicted. And in 1997, they suggested that the threat of addiction is very low, and that it's cruel to withhold obviously effective pain medication. And before we go further, prescription opioids do work. They're very effective in lots of pain applications, okay? Well, they said to the doctors around the world, and particularly primary care doctors who prescribe the majority of pain meds, we're being unnecessarily careful. So let's take the wraps off. Well, by 2008, opioids went to the most prescribed class of medications, eclipsed statins, which control your cholesterol. You wish your personal financial portfolio had the same rate of increase as the rate of prescription opioids. Over 350%, some are over 1,000%. Yeah, methadone went up over almost 1,500% in the space of just about 10 years, okay? Oxycodone, these are all forms of opioids, okay? All right, so what? There's probably a lot of older people, the population age, they probably had a lot of pain. It's probably reasonable. No, we use 10 times the amount of prescription pain medication as any other country. Within this country, anybody who lives on either coast uses 10 times more than people who live in the middle of the country. There's tremendous variability in the use of these. And then there are other changes. By 2008, physician arrests for malpractice and misapplication of prescription privileges went up. Opioid overdose reports went up to 110. Now it's over 200% increase. Opioid overdose deaths, and when I did the slide, it was the #2 cause of accidental death. Now it's the #1 cause of accidental death. Prescription opioid overdose. Wow, that is amazing. But it's not just that. Other things happened as well. If you're driving too fast or you're driving erratically, a policeman will stop you and test you for alcohol. They practically never test you for drugs. But if they do, and when they did, there was a study in 2007. And by the way, this study did not stop people because they were erratic or swerving or anything like that. They just stopped them for when they were stopped at a stoplight and said, do you mind if I swab the inside of your cheek with a Q-tip? I'm not going to take your name. I'm not going to do anything else. I'm just curious about your blood content, okay? So remember, these were not people who were stopped for an accident. So they did over 1,200 of these, and it was voluntary. And the thing about these, a cheek swab, it's very good, it's very quick, very cheap to do. You can detect alcohol, you can detect most drugs, most opioids, not all, but most of them, but you can only detect them for about 3 hours. So what I'm about to tell you is the proportion of people who were just stopped along the highway and said, yeah, go ahead, who had been using a drug in the last 3 hours. So about 6,000 drivers were tested. 11% were positive for an illegal drug. Most of that was marijuana. About 5% for medications, and 16% total. That's exclusive of alcohol, which was round numbers 10%. So about 26% of people driving on the roads had something going on inside them that was compromising their ability to drive. So when we talk about prescription opioid problems, of course, overdose death is by far the most serious. Addiction is the next serious. But also, don't overlook driving. Okay, so here's a study that I find very interesting, and how, and it's the reason, by the way, that substance abuse along with mental health are now essential conditions as part of the new Affordable Care Act. And here's one of the reasons why. Here's a study that was done in Boston University Hospital, and they looked at, I believe it was 87 patients who were in treatment for opioid problems. They were in a methadone clinic, and they were going to their primary care doctors, but their primary care doctors never asked them about any use of opioids. They didn't know that. Yeah, so what? It wasn't any of their business. Maybe, but here's what happened. 100% of these 87 patients received at least one medication that had a significant drug-drug interaction. It caused a problem. Average number of those was about 5 per patient. 15 of these 87 patients, or 17%, had to go to the emergency room. Now it is your business because you're paying for that. And it cost a great deal of money not to know about what's on board when you're being prescribed another drug or another medication. Okay, here's a final one on this topic. These are CDC records of medical errors, and there are lots of them they look at. This one here, there's 2 different graphs that show the same kind of thing. I mean, I hope you can see it in the back. The lines go way up. Again, you wish your financial portfolio had growth like that, okay? But they're alcohol and drug-related fatal medical errors. That means that a medication prescribed by a physician did not take into consideration another drug that had been previously prescribed or not revealed to the patient, and that produced a fatal medical error. They're going up like crazy. Okay, so wow, this is bad. It's bad for driving. It's bad for health care. It's bad for health care expense. What is going on? Are there any studies that give us any clues about what is going on about this? And I'm going to give you 2 that I think are pretty interesting. First one was done in West Virginia, and it was done there because at one time, back in 2008, West Virginia had higher rates of opioid overdose death than any other state. That's not true any longer. Now it's Vermont and New Mexico. You may have heard that the governor of Vermont, now let me underline this. This is Vermont. This is Ben and Jerry. This is cows, skiing, healthy climate. The governor of Vermont dedicated his entire 1 hour and 30-minute State of the State speech to one topic a few weeks ago: opioid overdose death. His whole State of the Union. No schools, no taxes, death from opioids. It's overrunning that state. So here's a study in West Virginia about this. So they went back and they looked at the records of people who had gone through the University of West Virginia health system and had died of a prescription, that is to say, a pharmaceutical opioid. You'll see in a minute why I'm not calling it a prescription opioid, okay? And they looked at that, and the death rate was very high, 18 per 100,000. And here's the take home. Of all these people that died, and they had a pharmaceutical opioid, they had OxyContin, they had Vicodin, they had Percocet, Percodan, all the prescribed opiates, not heroin, okay? They had prescribed opiates. But only 36% of these had any recorded prescription by a physician. You're not sure what that means? It means that you can't hold the doctor responsible for this. They didn't get the pharmaceutical opiate from their doctor. They got it from their friend. They got it from their medicine, their grandmother's medicine cabinet. They got it from the internet. They got it from a lot of different places, but they didn't get it from the doctor. Now, by the way, you could predict who was likely to have an opioid overdose death in West Virginia, in this very big sample in West Virginia. If they had had a mental health or substance abuse history, or if they'd had a previous episode of opiate overdose. By the way, the doctors never asked about any of this. But if they had, and they were there, or if they were receiving a benzodiazepine, like a Valium or a Librium, Syrax prescription, they had a much higher likelihood of dying from prescription opioid overdose. Huh, that's interesting. So there's a lot of pharmaceutical opioids out there. It looks like only about 64% of it comes directly from the, it looks like only 36% of it comes directly from a physician and 64% comes from other sources. I'm not sure what we do about that. How do you clamp down there? Okay, we'll hold those thoughts. Now let's go across the country to Oregon. And now we're talking about the, I think it was the, group health in Oregon. Now the thing that's interesting about this is all of these patients had a primary care doctor. All of these patients, and the primary doctor had an electronic health record for every one of the patients, okay? So also it's very different from West Virginia. Couldn't be more different geographically. But something interesting, the death rate was a little bit lower, but as a matter of fact, had exactly the same predictors of who was going to die of an opioid overdose. Once again, group health looked, at the people who had died from so-called prescription opioid overdose, and all of them came from the physician. Now here, you can hold a physician at least partially responsible, and they didn't ask about mental health or substance abuse history. They didn't ask about prior history of any overdose episode. They didn't check to see if there was a prior benzodiazepine, Valium, Librium prescription. They could have, they didn't. I'm not condemning them. Most physicians at that point didn't. But it's a problem. And 27% had a prior overdose incident and still got. Another thing that was interesting from this study is the times where you were most susceptible to die or within 1 or 2 days after your original prescription or 1 or 2 days after a refill. Most of the refills were done over the phone. No additional questioning. So what are we going to do? The opioid overdose death rate is alarming. It's not going down. So the same pain management societies that in 1997 said, maybe we've been too lax with our prescribing, have now revised their suggestions. And I think I have some of them. I think these are perfectly sensible. I think they are not going to interfere too much. They're a bit of an annoyance with medical practice, but I think it's warranted. I'm not a physician, but that's my view. First, these two pain societies say if you're going to prescribe opioids, screen and discuss substance use with your patient. That's not too much to ask. Take a urine. If you've got opioids on board, if there's cocaine in that urine sample, that's something to discuss before you prescribe opioids. Just talk to the patient. Ask what their recent use of substance is, and then get a patient contract. Now what that means is, Mr. Patient, I'm about to give you something that's a controlled substance. I want you to promise me you're only going to go to me and nobody else, no other doctors. And I want you to pick your pharmacy. I'm going to write the prescription to that pharmacy, and I want you not to go to any other pharmacies. This is one way we can control things. Yes, it's a promise, and people can break their promises, but it's a good start. Next, how about educating the patient and educating the family, especially since many patients who get these medications are elderly. They have pains. Excuse me, I'm sorry. And talk to them about safe prescribing, not sharing your medication with your sister if she's got a bad back. Don't just give it to her. And safe storage. Interesting, in Philadelphia, in the height of the depth, I guess I should say, of the real estate crisis, in Philadelphia, they stopped open houses on Sundays. Do you know why? Yes, that's correct. People came to the open houses, cleaned out the medicine chests of all the opioids. It was so rampant that they had to stop it, okay? So safe storage is very important. Urine screening I talked about already. And I'm afraid you have to use it's a little bit more expensive, an expanded test panel to test for some of the prescription opioids, but it was recommended by these pain management. And finally, where possible, use of prescription monitoring systems. A prescription monitoring system, frankly, is a pain in the neck for a physician. What it is a separate computer that's on his desk. He's got an electronic health record and he enters your prescription in there, and that's one thing. But for opioids, he goes to a separate computer and he puts in John Jones, 100 milligrams, morphine equivalent, March 14th. And that's available to every other physician in Pennsylvania. And the reason there is it's an extra incentive for physicians to check to see that no other physician has prescribed opioids. This is a common thing that's done. People who abuse opioids will go to many physicians. So it's a good thing to do. It's got its limitations. One, most of the prescription drug monitoring systems don't exchange information across state lines. So if you live in Philadelphia, you could go to one physician, cross the river, go to another physician, go a little bit further south to Wilmington, go to another physician. So it won't catch that, but it's a help. Prescription opioid overdose is now recognized as a national epidemic. It's the only epidemic agreed to by the White House Office of National Drug Control, by the FDA, the DEA, CDC, all agree. So I think maybe I'll just stop there, and happy to answer any questions if I can possibly do so. Thank you for your attention.